So we're ready for the abdominal exam. Let me have you lay on your back, and I'll raise the table up so you can have that support. And I'm going to get a drape for you. And here's what we'll start with. I need to be able to see the lower part of your abdomen, so I'm going to push your waistline down to about here. Is it elastic enough to come down?
Not. Just...
Yeah. That'll be fine. Because this is exposing the abdomen, and if it's not done that way, then I have students that will actually try to examine the abdomen through the clothes, and you never do that. You have to be able to expose all parts of it. So I'll put the drape right here at the base. Now I'm going to go on and let you bring your knees up, both knees. Particularly important when we get to the palpation part, it relaxes the abdomen better, so we want the knees up. Now, first, the key thing, once I've got you set up like this, the first thing I do is I stop and look. And I'm looking for contour, I'm looking for skin changes, any rashes, anything that is a problem. I'm looking for scars, and I'm also looking for pulsations. If I had a patient, for example, that had a large a mass in aorta was enlarged, for example, I could see a pulsation. So in your case, the abdomen's flat, the contours is what I expect. I don't see skin changes, either scars or rashes, and I see no pulsations. So that's looking first. Now the next thing I have to do before I touch you is listen, because if I touch the abdomen, it's going to get stirred up. So I have to listen first. So I'm going to listen, and I'm going to listen with the diaphragm rather first, and I'm going to listen for bowel sounds. So and they're usually quite active. So. And when I say active, the small intestines are working all the time. So when I hear them, that's all I need to say is that I have active bowel sounds. Now I'm going to continue to use my stethoscope, but now I'm switching to the bell. And I'm listening for what the medical term is bruits. It's, again, the arteries should be quiet when the blood's flowing through them. And if it's restricted in some way, it will make a noise. So you have 5 areas I'm going to listen to that I'm listening for sound. I should hear nothing. So I start in the middle, right in the middle above your belly button. And they go 2 places a little higher that are paired, and then 2 other places are a little lower in the lower quadrants that are paired here. And I don't hear anything, which is what we'd expect. Now, the next thing I'm going to do is percussion. It kind of sounds like I'm hitting you, making a drum type sound. And the abdominal cavity is mostly air, so I'm going to get kind of a hollow sound. So let me take a look. Now that's where your stomach is, so it's the most hollow. Then I check the other quadrants to compare it to that, and it should be, again, mostly hollow, and it is. Also, when I'm doing this, let me take one more pass. When I'm doing this, I'm listening for the sound. I'm also interested in you telling me if that's tender at all. So let me do it again, and you think about that. Any of those 4 spots tender when I do it?
No.
Okay. So that's the percussion part. Now that's the general percussion. The second is percussion tells me about size of things too. So I'm going to check the size of your liver, estimate the size of your liver. So let me pull this up. I'm going to start right under your bra. And that's kind of a sound that's not flat, and go down. And then when it gets dull, that's the top of your liver. And then I come down here and work up till it gets dull, and then I'm estimating the distance between there. And in yours, you have about 5 centimeters, and that's not an enlarged liver, so that's a good sign. So that's percussion. The palpation. I'm going to start with light palpation. I'm not going deep at all. I'm trying to decide if I feel anything, or you can tell me if it's tender. So, and I'm really checking the abdominal wall. I'm not trying to get down inside the abdominal cavity. So, as I palpate each, and in this instance, I'm just using one hand, but I'm also going to go in all quadrants, and it's fairly gentle. I'm not trying to get very deep. And you tell me if any of that is tender, okay? Now the deep palpation is different because I'm going to go, shouldn't be painful, but you tell me if it is. With deep palpation, I'm going to recommend that the student put one hand on the abdomen to be relaxed and be the sensory hand, and the other hand on top of that to push down. So in each quadrant, you can see it feels quite a bit different. I'm getting a fair amount deeper in all 4 quadrants, kind of rolling my fingers just a little, and I'm trying to see if there's anything. You're telling me if it's tender. I'm trying to see if anything's rigid or if I feel anything that's firm. So I can do that and tell that there's no rigidity, there's no tenderness, there's no masses. Okay. Now there's a couple of specialized tests that I want to show you. One's for gallbladder. It's called the Murphy sign. Your gallbladder is tucked up here underneath your right rib cage. So here's what I'm going to do. I'm going to curl my fingers under your right rib cage fairly firmly, and you're going to take a big, full, deep breath. Okay. Now, you didn't react, so I'm assuming what would be positive is if that caused sharp pain, or you had to stop, you had to halt your inspiration. And so it looked like that was negative.
Right.
Okay, good. The second thing is actually for appendix, and there's a section on your lower right quadrant called Murphy's McBurney's point. Rather, this is Murphy's sign, McBurney's point. And if I go to your ASIS on your ilium here, and your umbilicus, halfway in between that on a line is a spot that's where your appendix should be. So I'm going to push directly over that spot, and you tell me if that's tender. So that would be no tenderness at McBurney's point. The other thing is if you did have an area of tenderness, and I wanted to check what we call rebound, I would get over the area of tenderness, and you have to do it gently because you're already tender there, but I would push in gently as far as I could go, even though it hurt a little bit, and then I would let go all of a sudden like that. And you would tell me if it hurt more when I pushed in or when I let go. And if it's rebound, it means that I've kind of let the lining of the inside of the abdominal cavity kind of flutter up and down, and if it's irritated, it's going to hurt. So this is exactly what it would be. I would say, let's say you're tender in this spot. I would go over that spot, and then I would say, now, that might be a little bit tender, but now I'm going to let go all of a sudden, and you tell me if the tenderness is more. And if it was, then I would help decide it. That's called a peritoneal sign. That will help me decide. So. Okay, so let me back up and talk through a couple of things. And I'm really thinking of the kind of mistakes that students make. First of all, the drape is important. The knees up are important. Students are fairly good at that. I'll tell you what they're not good at. I see a lot of students that will have because it's pretty normal for a woman's or a man for that matter to have your garment at your belly button. Well, I can't do an abdominal exam for your lower quadrants. I can't do it too close. It's not proper. So the first thing I have to do is I have to pull that down enough to expose that lower quadrant, both lower quadrants. So that's an important step. The second thing is to reemphasize is look first. Don't start. You tend to want to do, when you think of abdominal exam, you tend to want to kind of start doing the abdominal exam. Well, it's first to look. So I'm doing that inspection part about contour, pulsations, any skin changes, scars, rashes. And then even before I touch, I also have to listen before I touch. So that's why the next phase was the auscultation of and the minute I hear your bowel sounds, I can quit listening. I'm not overly worried if I don't hear them everywhere. But if I started here and didn't hear anything, I would keep going to another quadrant until I heard bowel sounds. Once I hear bowel sounds, then I can just stop and describe them. And the descriptions are usually going to be absent, which is pretty abnormal, hypoactive, active, or hyperactive. That's what. So you don't. That's the medical description, and yours were active, which is the part we want. And so the other auscultation, and I want to reemphasize this. These are locations for the arteries that we did the breweries for. This is commonly missed, so let me emphasize this. Your big aorta divides right here and goes to each leg. So this bifurcation is about 2 inches above the umbilicus. So I want you to listen to the aorta right there, about 2 inches above the belly button. And then the renal arteries are actually higher and closer to the midline than students normally think. So I'm going to ask them to go up on each side, fairly close to the midline for the 2 renal arteries. Those are paired. And then the iliac arteries are right in the middle of each lower quadrant. So that's 1, 2, 3, 4, 5 spots for bruits. And all I'm doing is asking, just listen with the bell to see if I hear anything. The percussion I did, and I kind of started at the tympanic bubble of the gastric, because it's so obvious. That's the most tympanic, so I'm kind of using that to compare. But I do percussion in all 4 quadrants, starting with the gastric bubble. Normally my description for that is variable tympany, because it's not going to be exactly the same in each quadrant, but it's more air than it's not. So if you had some kind of a mass that was going to be, tympany means something's relatively hollow. If you had a mass of some kind there, it would be dull. It wouldn't be tympanic at all, so it tells me something about that. So I make that interpretation by sound, and then you make an interpretation for me that says, any time that I did that percussion, was it tender? So that's really a peritoneal irritation sign, and if you said no, then that was fine. The second percussion, that was the percussion for the quadrant. The second percussion was liver. Bates recommends that, I don't know if it's critical, but they recommend that you start just below the breast and get above the liver. And if you're above the liver, then that sounds resonant, because that's the lung sound. And it doesn't get dull till you get to the upper border of the liver. And then you start in the abdomen to come up, and then it gets dull when you get to the liver, and then you're estimating the distance. It's just an estimate, it's not an actual measurement for that. So that's the second part of percussion. Palpation, probably, we always make sure our student does both deep and light. So the light was the one-handed, the deep was the two-handed. And it felt a lot different when I go deep, so you can see the difference. Then the specialized test, Murphy's for gallbladder. Probably the most important thing about it, and you can sense for me, is this is not designed to hurt you, but you can tell that this is fairly firm. This is not gentle, because I need to trap that, and then when you breathe in, then your diaphragm is coming down. So basically, your diaphragm is coming down and my hands are stable. If the gallbladder between those two structures was inflamed, you'd have a lot of pain. So that's the recommendation for Murphy's. And the McBurney's is just a tenderness at a certain point, because that's the main anatomical point for the appendix. And then, of course, the rebound, we talked about that a little. The rebound is you're trying to kind of cause a reverberation of sorts of that peritoneal lining. If it was inflamed, it would hurt. So in that case, it would hurt more when I let go than when I pushed in, which is not easy to interpret. But if that was the case, it would be pretty prominent. So.